Fantastic. Well, thank you. Thank you for having me. I'm giving my third training in the series. So just to kind of briefly go over my first two, if you're ever interested and weren't involved in the ones I gave in January or February, I covered a lot of the identity and historical context of queer identity. And then for my second training, I went into more of the organizational level, micro to macro level improvements we could make to get better outcomes within the queer population. A lot of that was, predicated on the data of North Dakota and what we're seeing with our results. So if you're interested in learning more about that kind of work, you can always talk to me about that. For folks who have been here, you've already heard me introduce myself twice, so here's the third time you're going to hear me introduce myself potentially. But the things I like folks to know is that I've born and raised in North Dakota. This has been my area in my life for as long as I've been alive. It's something that I have a lot of passion and dedication for, that I will be serving North Dakota for my life. I am a survivor of suicide within North Dakota, so this work is very personal to me. And I want to make sure that I can do the best I can to provide opportunities to uh, basically reduce suicide. All my work is effectively through a suicide prevention lens. I myself am part of the queer community, so I have seen a lot of the ways specifically that organizations and institutes have uh, a lot of our queer individuals have fallen through the cracks there. I specialize in data within the state, so I'm the LGBTQ plus data expert. And what that usually means is that I look for all the data that we have across the state for queer populations, as well as advocate for including that kind of data on surveys. So I've worked with our behavioral risk factor surveillance system, that's the BARFIS, and then the youth risk behavior survey system to generate data for our queer populations. I work as an LGBTQ plus care coordinator, and I also work with a nonprofit Harbor Health Initiative. So I have a lot of work at the clinical level. I have a lot of work at the community level and nonprofit level, and then just do a lot of the data. But that's kind of my background and what I bring to this work for our education today. For our presentation, we'll be talking a little bit about some of the statistics. Some of them will be familiar to you, but I'll be talking about them specifically in the context of suicidality for this module. And then I'll be talking a lot about the kind of resiliency risk factors for these queer youth. And then I'll tell you about all the stuff that we're doing right now, the organizations doing it, and then some ways that you could get involved with either those organizations, training on suicide prevention, or resources you can use after this. People are welcome to email me at any time. So after this presentation, if you ever want to follow up and go, hey, Faye, I was looking for this one resource, what is it? I will help you out. So my email will go in the chat at some point. The very first thing that we have here is just some participatory exercises. So I'm going to get right into that. So you can answer in the chat A, B, C, D, E. How many of our LGBTQ plus youth have seriously considered suicide in North Dakota? And we have data on this with our youth risk behavior survey. So put a letter in the chat. I'm getting two Ds. Anyone want to try a different answer just to see, or are we sure it's the D? I got E's, I got some E's. So we know it's pretty high, it sounds like. So the answer, I'm not going to give you necessarily just a direct answer here. It is E. So the answer for this is E, but this is how it actually breaks down with their data and statistics. So when we look at ever considered for our LGBTQ plus youth, we have about 65% of them answered that they'd seriously considered, compared to our straight population, which is 22.1%. One thing you'll understand about me is that I think all of the numbers we see here are ridiculous. Like, this to me is a health epidemic, and it's a reason I spend so much of my time in life working on this, because 22.1% of our youth total seriously considering suicide to me is alarming. It is something that I don't know why we're not immediately addressing it with a lot more effort. But looking into more data on that for making a plan. So in terms of suicidality, that's kind of the next level of risk, is people actively making a plan, where it becomes a little bit more of a risk factor. And we have about 50.7% of our queer population making a plan, queer youth in particular, compared to about 16.8% of our straight population. So really much higher level risk when we're looking at that. And then when we look at actual attempt rates, it's 29.3% compared to the 7.5%. And one of the things that's kind of interesting is that we ask these youth if they've made an attempt, but we don't ask like what that attempt may be. So it's what the youth consider an attempt. And something that I hypothesize, this isn't in the data, I do wonder that if the youth kind of have a broader consideration of what attempts mean. Because if we are looking at the actual statistics here, it would suggest that about 10,000 attempts were made within the time this data was taken, about 2021. And we usually see there would probably be a higher level of lethality compared to those attempt rates. So I think it's still very serious if they've considered something an attempt, but I think that we might be missing a little bit of that data, what attempts might look like for youth. They also have less access to lethal means than an adult might, unless you're considering things like firearm access, if that's something that's in the home or not. But it can be harder for them to have a lethal attempt. As I go through this, I will say this is suicide information. This is discussions on suicide. So I always like to talk about 988. And if you ever need to like step away for a second, as this information can get very heavy, um, you never know how it's going to sit with you, even if you are a trained professional. There are times that I will listen to this data and maybe just kind of turn my stuff off and cry for a little bit. So keep in mind, this is really heavy stuff we're going to be talking about, and make sure you're taking care of yourself as we go through it. So the next question I have, so the suicidality is very high. So for question 2, how long have we had access to this data in North Dakota? How long do you think that we've known this as kind of a state that we had numbers like this? And you can again put in the chat A through E, so A being just this year, or as E would be 2011 to 2014. How long have we known about this in North Dakota? Kind of a diverse range of answers. That's pretty cool. So I had to do research into this, basically. I had to investigate this because I kind of am the person doing this in North Dakota. Like, I am very much the person leading a lot of these efforts and making sure that we are looking at queer populations and suicide prevention. So I'm going to track down what I have ever seen happen for this. The last thing is in September 2022, I talked about the Youth Risk Behavior Survey data. So this was about a year and a half ago now. I had a published LTE talking about the outcomes of trans individuals, in particular suicidality. But before that, in 2021, I published the LG Plus School Climate Report, where I also talked about the data impacting our queer youth. And I actually sent this to every superintendent all across North Dakota so they would have access to this data too. In 2020, we actually got the results of our 2019 Youth Risk Behavior Survey, which talked about a lot of the high levels of suicidality. So that data that you see, some of the data I'm quoting, this is what I see. This is like the raw data I see of the comparative data before I put it into nice looking charts. So before that, we actually had a conference that the American Foundation of Suicide Prevention hosted in 2019, looking at ways to reduce or mitigate LG plus suicidality. So we were looking at this in 2019, which is now 5 years ago, almost to the day, that we were putting some effort into it. But even before that, in 2018, I had published a story talking about the data from 2017's Youth Risk Behavior Survey about the high level of suicidality put out as a journalistic article at the time, which, fun story, got me invited to UND to talk about it, but not because they realized I was the writer of that article. They were looking for someone who did that work and invited me and figured out afterwards I was the one that wrote that. But even before that, we actually had a suicide prevention plan in 2016 where they devised a plan between 2017 and 2020 about ways to reduce suicidality. However, the through line of this is that we have had good access to this data since 2018 at least. North Dakota specific, Trevor Project or national data would have showed you the same stuff. But a lot of this, at some point, the people that were working on it quit, left, moved the state, and the project died. There is no organization that I'm aware of that is working on that kind of a level of intervention, except for very specific things we'll get into later on. But arguably speaking, we've had at least 8 years of knowing this is a thing. And people like myself that were advocating very strongly for it to be a thing. But still, as I talk to people today, I feel like no one knows we have any of this. So I appreciate times I can talk about all the data that we do have access to. So that's kind of how long we've been looking at it. The actual answer was about 2016 forward, whatever letter that corresponds to. I was tricking you. That was more of a educational exercise than a true or false thing. So here's a question you can put true or false to, or provide opine on it if you want to. We have a high suicidality within our queer community, and that's evident by the data. But we still had a high suicidality with our straight community. We had 22% compared to 65%, as you just saw with our data. So the question is, yes, we have a higher level of suicidality in queer populations, but isn't it still better to do a generalized approach that would help all populations? Is that true or false? Yeah, I need to make that question make more sense. I haven't found the perfect way to say it. But basically the idea is if we have limited time and funding, shouldn't we always do approaches that are going to help everyone as opposed to approaches that are specialized and would only help a specific part of the community? And that's the question I'm kind of putting on the table. I'll let you sit with that for a second as you can put answers into the chat. As you see with the answers I've given you before, they've all been a little bit tricky, and that continues to be for this one. And that's the wrong question to ask. And the reason I'm asking you the wrong question is because I've been part of a lot of board meetings where this is a discussion. And it's a discussion about funding and time and effort and how do we maximize our results. And if we think about LG plus individuals within our population, they are a minority population. So how much effort and time should we do for something that would only impact a percentage of our population? But what ends up happening when we have those discussions, especially when we're looking at, let's say, macro level population health or intervention, is that people will prioritize generalized approaches, ones that are just, let's say, suicide prevention education, resiliency education, sources of strength, and stuff like that, that can have an impact on your total school population. However, if they don't include and incorporate specific stressors that can happen for minority populations, whether that be indigenous or whether that be queer, then you're not reducing the discrepancies at all, and they are still going to exist in the system. A way to understand this to be visualized is I'm going to pop up that data we just looked at, and we can assume all youth have a similar level of suffering that could result in higher suicidality. They all might be dealing with housing insecurity or abusive parents, or things can be happening that cause suicidality, not because of queer identity. So we have to assume the discrepancy within these populations is probably largely due to the minority stress of them being queer. And if we're not addressing that within our total kind of holistic ways of addressing community health, this is who is missed. And the interesting thing about that is if you start to run the numbers on this in particular, what happens is this. When we look at total populations, about 20% of our youth population is queer. And it kind of goes up and down depending on what you're looking at, but it's about 20% compared to 80%. So it's about 1/5 of our population. But when you actually apply the total number of suicidality, of suicides or attempts and all of that together, and you look at the raw value of it, then it's actually about 50-50. So trans individuals make up the raw value about 13.2% of suicide attempts, because even though they're a minority, so many more of them will actually attempt suicide that the value becomes so much higher. Same with our LGBT plus youth, same with our LGBT plus youth. So when we look at the total value, it's about 50-50. They're not actually a minority when we're looking at the outcome data of these populations. And then another way to look at that, just to hammer it home more, this is just a bar chart putting them next to each other. So that's the total amount of suicide attempts in these populations between LGBTQ plus LGBT plus youth and straight youth. And then another way to look at that is that blue bar you see in the screen, that's the people that you had missed if you do a generalized approach. So you miss about 40% of your target audience if you're not incorporating things that actually help our queer youth. Now, the trick question I asked you is, should you do a generalized approach or a specific approach? And that's the wrong question. All the approaches from the ground up should integrate some ways to address and mitigate suicidality because of any stressors that can exist in that environment. And that could be your minority stress factors, that could be lack of access to mental health care or adequate health professionals. Like this has to be incorporated into everything that's done. Otherwise, even if you did the best job in the world, there is still about 40% of the population that is suffering and you're not helping, and they continue to fall through those cracks. What we've seen with public health and public policy is they all often have done a generalized approach, which means the discrepancies we see in the system continue to be perpetuated in that. So something has to happen where that is addressed. It can be a mixture of generalized approaches and specific approaches, but the point is if you only do generalized approaches that don't account for these things, you're not really going to help these populations. You're not going to help them in the ways that is causing higher suicidality for them. So that whole question was just to make that case, that standpoint. And I will say that I'm arguing this, and there is evidence for it that your approaches that are more holistic will actually help out everyone more. But it's still something that can be debated within policy and within lack of funding. I think it's always going to be a funding issue. Like if we had unlimited time, funding, and effort, we would obviously do everything, but we're often compromising with the resources that we do have. So I'm going to look at state data. If you're part of my previous trainings, this is actually going to be very similar. So I'm going to go through this. I wouldn't say relatively quickly, but like I mentioned, I'm going to tie it to suicidality. Because when we look through these things, I want you to think about the idea of a risk factor. And I don't define this or anything. I think it's actually such an ubiquitous idea within suicide prevention. I don't have to go into it too deeply, but what a risk factor is basically something that can increase the likelihood that someone might think about suicide, make an attempt, or sorry, make a plan or make an attempt. So when we look at the adults, this is from our behavioral risk factor surveillance system. We see that our queer adults have reported a lot of things that we could consider adverse childhood experiences, which themselves can be risk factors. So a lot of our queer youth reported that there was an unstable person in their home, that their parents were divorced. And that's not to say divorced youth are going to suffer more, but there might be reasons that divorce happened that could be related to violence. There might be a lack of access to resources because of being in a single parent home. There's a lot of reasons that could create higher risk factors for these kids. They also have a much more likelihood to have parents who might be problematic drinkers or might have issues with substance abuse or serving jail time. Basically, there's a lot of things that these queer youth could be going through that could be impacting risk factors in their life. This was this was the adult data. So these are the experiences that our kids of like the 1980s and 90s had. So when we think about that, we can think about when we get into this youth data, it's kind of been consistent the entire time. Like the levels of marginalization or minority stress that this community has experienced has really been very consistent. So going down, looking at other things that have happened, this is looking at sexual abuse and physical abuse, which is an enormous risk factor at childhood adverse experience here. But a lot of our queer youth have had disproportional experiences with things like sexual violence, as well as just violence in their life. There's a lot of reasons you can kind of think about this or ways this could manifest, but the ways I typically understand it is that a lot of times queer youth don't see how they fit into systems, and they don't necessarily trust systems as things that can help them. In my own life, I can share that my parents were very violent. But from a young age, I didn't think that there was any resolution to that. I didn't talk to anyone about that. And I didn't really have any support in my life to be able to identify that was wrong. So because I didn't necessarily connect to or trust any of these systems or my way and how I fit into them, there was no early intervention that could have stopped what becomes chronic abuse or what becomes terrible things that can happen to these youth. So we can see that there's a lot of risk factors that go into queer adults in particular, and a lot of experience they have that is going to increase a lot of the potential suicidality that they can experience. The other thing I'm looking at here is just general outcomes here. So high likelihood of depressive disorder. Compared to straight populations, at least there's a discrepancy. So less likely to be able to concentrate, a lot of bad mental health, feeling like they've been intentionally harmed by others, or even looking at maintaining health, like going to the dentist or even sleeping more. Good things tend to be less in this population, bad things tend to be more, is how we can see it play out. And there's a way that these risk factors compound in the same way adverse childhood experiences can. Your anxiety, depression can make you less stable in other areas of your life or make you less likely to, continue to go to the doctor or get your teeth checked out or even be able to afford that, which means you might have bigger dental bills later on that you can't afford, which could create chronic pain. A lot of these things tend to cascade out where they become bigger and bigger problems. When we look at our youth, like I mentioned, it's very similar to these adults. So this is the previous slides were our adults from the 2022 Behavioral Risk Factor Surveillance System. These are our slides from our 2021 Youth Risk Behavior Survey. So this is how our kids are doing right now. And what you can see is the blue bars are kind of better things. Like you want them to eat with their family, you want them to talk to your family. Typically that's good for social cohesion. And you see that it's just dramatically less for our queer population. When we look at hurt by family, so something that's not good, you want less of that. You see that increasing for our queer population. I'm going to talk about ways specifically that's going to play out with our risk factors, sorry, protective and risk factors a little bit, so I won't get into it too much now. But really what you just need to take away from this is that our queer youth aren't doing well. Their mental health isn't good, they don't get a lot of support, and they don't necessarily trust our systems are there to help them in the same way that our other youth might. A lot of times they can experience bad things in their life. That could be violence in the school, it could be at home, where they try to find resolution for that. They talk to the authority figures, whether they be parents or principals in a school, and they can be completely disregarded. And when that happens, they just give up. They give up on ever feeling like they can actually have peace or that their feelings matter or that they have agency. A lot of those can be shot down early on in our queer individuals' lives. We also have data that we collect, the NDVDRSS. This is a state data metric system that comes from, as far as I understand, it's like emergency room data. Like this is data that we collect from the hospitals in particular, and it's where we see a lot of our state data from hospitals represented. So people who go in for suicide attempts, we collect data on that. People who go in from surviving a suicide attempt or going in for mental health issues, like those show up on this. And we actually been recording this. This is a little bit older. This is actually 2023's, like I think August report. It was the last, or September report is the last one that I had. The only thing I want to say in that is total suicidality for 2023, as far as we know, is less than 2022 and 2021. So the kind of good news is it seems like a lot of the impacts of the pandemic for a lot of different reasons that increase suicidality, we are starting to recover from that. And it seems like suicidality is starting to go down from some of the peaks that we saw due largely to the pandemic. That's a whole other presentation, but all you need to know is that it seems like we're doing better now in that we were recovering from the pandemic, at least in terms of mental health. Another thing I want to show you from this is other things that we track for youth suicide in particular is things going on in their life. So if you look at the slides here, it's school problems, family problems, depression, anxiety. But I want you to look at gender dysphoria here. So gender dysphoria was a common stressor or trigger for a completed suicide for 10% of the cases that they looked at. And I think this is really important to look at because if you look at the suicidality of trans youth in North Dakota, it's about 50%, like 46% say they have an attempt, which means about half of them do. Now, if you look at this being gender dysphoria, about 10%, trans individuals make up about 2% of our population, which means this is about 5 times higher than you would expect to see from that, which means that that lines up. And what I'm trying to say is that all of our data that we collect, the BARFIS, the Youth Risk Behavior Survey, the data that we're getting through our hospital systems, it all tells the same story. A lot of our data can be a little bit weaker because queer individuals are a smaller part of our population. It's harder to collect data on them, but it syncs up in a way that we can really look at it as being strong, prevalent data that queer individuals are 5 times more likely to looking at attempts or completed suicides. So it's a very real problem that we see in every way that we measure it. That's just to give you the data, and that's just to give you that we do have strong data at the risks that we are seeing. But what I want you to do is I want you to understand how this can feel like, especially for our queer youth. And if you treat adults and not youth at all, that's not a problem. These are experiences that your adult clients probably had. And if we're looking at the BARFIS, it seems like that's the case. It seems like queer individuals that are experiencing abuse today is exactly what they experienced 10, 20, 30, 40 years ago. There's going to be a lot of difference generationally, but it's kind of the same. I'm going to give you a very quick rundown on risk factors and protective factors for how they are going to exist for an individual. So I think the thing that people maybe don't pick up on sometimes is that risk factors and protective factors can be two sides of the same coin. A family can be a huge protective factor if they're accepting and loving and a place you can go to for support. It can be a huge risk factor if they are violent or a place of anxiety or insecurity or things bad have happened. And that's true of every environment we go to. Schools can be risk factors or protective factors. Friends are risk factors or protective factors. Home, self, hospital advocates. There are more to life than these 6 things, but these are the 6 ways that we can really interact or understand the clients or patients that we serve. So I want you to see that any way this plays out, it can be both risk and protective factors. And what you understand is that a person's life is a combination of a bunch of these different things. So on the right is an example of someone whose friends and advocates are protective factors. They are good allies. They are affirming in their life. They make them want to be alive. But their school is full of bullies. Their home is full of bullies, and they don't trust their doctor. So in this person's life, they have protective factors that are making them want to wake up, but they also have risk factors that make them not want to wake up. And even in themselves, you can have both protective and risk factors. Someone who's extremely depressed might be a risk factor to themselves. However, someone who is empowering themselves through something can be a protective factor. When I think about suicidality and I think about how it plays out, I literally see everything as a risk or protective factor, and that is everything can lead to or from suicidality. And that's why I consider myself a suicide prevention advocate. And that's why I work with everyone everywhere, because every single thing we do adds into the story of if we want to wake up or not. So I'm going to run through ways this can play out for our queer individuals. And when we think about some of the risk factors that can occur, the thing I want people to really gravitate towards is the idea of the family dinner. And one of the most powerful ways I've ever seen this play out was actually American History X. And they showed the family dinner in a ways that was radicalizing these young boys into white supremacy. And the way that played out was this father was extremely racist, and the boys initially challenged that, but were fought back and eventually conditioned into believing a lot of these racist ideologies of that table. The same thing can really happen with queer youth when they are at a dinner table and they hear their parents talk about queer individuals in very stigmatized or biased ways. A lot of times parents don't believe that their kid is queer. They think that their kid is quote unquote normal. So they will talk about trans people, let's say in sports, or they will talk about these freaks that are going into the women's bathroom and talk about them in very highly prejudiced or biased language, not thinking their kid is picking up on these messages while they're just trying to eat like a spaghetti dinner. So they are suddenly getting really scared and anxious and quiet and withdrawn, and the parent has no idea that's happening or why, because oftentimes kids start to feel like they're different at a younger age than they come out to their parents about it. It's about 4 to 5 years. I don't have the research in this like presentation, just from other stuff that I've done work on. It's a couple year difference. So there are messages that queer youth get their entire life about where they're going to be safe. And oftentimes people have very casual conversations about their opinions about what it is to be gay or trans in spaces where there are youth who are picking up on those messages, both for themselves and how they should treat other people. There has been current research looking at states that have a lot of laws that are prohibiting queer individuals in certain spaces have also seen an increase in hate crimes against queer folk. And we understand that not politically, but just through the lens of bias and how that can impact populations. This can be an enormous risk factor, because once you don't trust your parents as being safe, as a kid who is 10 or 11, who do you have in your life? Who do you talk to? Who do you go to? That is your number one individual for getting any service in your life, and they could be gone. So what ends up happening is all the things I just talked about, where the child can internalize a lot of negative messages about themselves. And there's a lot of ways to talk about child development that I won't get into necessarily, but like what ends up happening a lot of the times is a kid will perceive their parent as a good thing. Their parent is right about things. Like, they lose that at a certain age too, but when they're younger, they kind of see their parent as infallible. They see their parent as this like huge, awesome force. And what can sometimes happen is when their parent starts to talk about this negative way about who they are, they feel like they're the ones who is wrong. Their parent has to be right. They are the ones who are wrong. They are the ones who something is broken within them. And that's the ways they can internalize that, is they can start to hate themselves because they see that their parents hate people like them, and that's how they internalize it. So when we think about how safe our queer youth are, we have to really think about how safe they are at home and the kind of messages that they've gathered their entire life. This is kind of the start of a lot of the minority stress that can happen to them, but it can create issues of depression. It can also create things like homelessness, because When queer youth feel unsafe at home, they're more likely to run away from it. And when they're running away, they open themselves up to a world of abuse that could potentially happen, including things like trafficking. But when their home feels fundamentally unsafe, they're not in a good place. And they also might not want to talk about it because they could be afraid that their parents will find out that they are gay or trans. And so when they have these problematic behaviors where they are running away or doing these different things, you'll try to talk to them and go, hey, what's going on in your life? And they will say things like, oh, I just thought it would be cool to do that. They won't be honest with what's going on because they're afraid to come out or afraid to be open about who they are or why they are suffering because of a lot of the things that can happen if you're an out queer student. So not only is there all these different risk factors that can occur for these individuals, they also are less likely to talk to us as professionals because of so many reasons they could be afraid to do so. So these are a lot of things you might have to untangle if you have clients who, are coming from families that aren't particularly safe, where you do have to build a lot of trust with them, where you do have to, really find ways that you can advocate for them, listen to them and assure their safety to talk to you about what's going on. Because if we don't know the source of their struggles or anxieties, we're not going to actually help them. We're just going to help the phantasms they bring up to avoid having to talk about it. The other thing to look for risk factors, so that's kind of home. In a lot of ways, home can be a risk factor, but school in particular is a very scary place. So school can be a lot of different kind of risk factors, and youth are very likely to experience bullying. We had talked about that within our slides with the Youth Risk Behavior Survey, but our queer youth are twice as likely to be bullied both on school property and online. And that's just looking at other students. There are a lot of scary places in the world for queer individuals right now in online spaces where they can be targeted or bullied. Um, I don't know if anyone here is aware of this, but there's actually basically a meme going. I don't even know what you call it, an attack meme, but trans individuals who produce content will very often get people coming onto that content and saying you need to 41% yourself, which is a reference to the suicide number that was in the US trans survey. So it's a coded language to tell queer people online to kill themselves is common behavior. Like I want to stress that is expected and common behavior that if you are a open and out person on the internet, you are probably going to experience that. That's the life that queer youth have to navigate. But when they become afraid of school because of bullying, there's a lot of things that can happen. Like they can talk to their teachers about that, like, oh, this person is bullying me and they're saying that I'm gay or something like that. And the teacher might go, deal with it. There's a lot of ways we don't handle bullying in the school system that well for I'm not going to blame teachers on this. I think that there are several struggles happening all across our education system right now where it's difficult to really make sure all of our queer youth in general are safe, but queer youth as well. So when they feel like they can't be safe at school, they don't go to school. The problem is when they don't go to school, they get punished for that. That's penalties. That could be truancies. That could be they could get cops called on them to go to look at their house and bring them into school, and they might not be going because they don't feel safe. When we look at youth that kind of act out in this way, we often think about it as like delinquent behavior is a word that's often brought up, but we don't often look at it as a trauma response that these kids are just trying to live. They're trying to exist in a way that makes sense for them. And oftentimes the ways they try to mitigate this is that they get further traumatized by our systems. So there's a chance that they can be outed if they ever kind of talk about this. There's also, I don't know if I get into it here. Yep. They try to potentially use substances to cope with that. So they could be getting bullied at school and feeling depressed and scared about that. So they don't go to school, but then they get punished and they're truant and they get worse grades because they get zeros on their assignments. And then they get less invested in school as an institute, less invested in college or their future. And they have all this pain they're dealing with, so they turn to substances. But if they also don't feel safe at home, they're keeping these substances in their backpack or on their person. They're coming to school with them, and eventually they're going to get caught with that. And then they're looking at juvie or looking at some kind of punishment for that. So every way they kind of try to figure out how to survive in these systems is another way they can be just hit back down. And I can tell you personally that this is a lot of my story, and this is a lot of what led to my initial suicide attempt was because I couldn't find help. I didn't know how to deal with these things. I didn't know who to talk to. At an age 13, I assumed that I had to figure out these things because no one was going to help me. And when people eventually did try to reach out to me, I just assumed that they didn't care and were just doing their job. I was that de-invested in our institutes at that age to the point where I couldn't even be helped by the time I was 17. Like I was done with all of that because of years of not having any adequate way to address the bullying I was experiencing or the things that were going on in my home life or at school that I was checked out. So there's a lot of ways that these kids a little bit of trauma can kind of cascade into very significant problems where if they don't feel safe talking about their queer identity, we're never going to know. Recall that line about people that were missing in generalized approaches. Those are the people that we're missing if they don't feel safe coming out to us. If they don't feel safe talking about what's going on in their life, we are missing those people. And that's why a lot of the times, if we don't create safety avenues for these kids to talk to us about gender orientation or sexual orientation and gender identity, these are some of the abuses they experience, which lead into a higher level of suicidality because there's a lot more risk factors. They can drop out. Suicidality, depression, substance abuse, these are all things that can occur because of the trauma they experience within the school systems. So what's the intervention for that? We often have social workers or potential student counselors that would intervene, or public health workers that are supposed to be helping these kids that fall through the cracks. But there are a lot of caseworkers that I know who don't believe LG plus identity matters, and there's very few systems that account for it. That whole exercise I did in the beginning about generalized approaches compared to specific approaches, to this day, most professionals I work with are in the mindset that queer identity is just, whatever, we'll put that over here. We'll just try to help everyone. And that way it'll help the queer students, it'll help our Indigenous students, it'll help our white students. Like we'll just help everyone and it'll all work out. And it doesn't. The discrepancies continue in our systems. So I deal with these barriers within my work all of the time where I know that people don't treat this as seriously or they don't think it matters as much because they don't understand the discrepancies that happen for these kids in particular. To really hammer this home, I talked about the Youth Risk Behavior Survey. There were 3 larger school districts who refused to take that survey because it included LGBT plus questions in it. I want you to understand that there are a lot of institutional barriers. You might already experience these throughout our entire systems of government and intervention and public health that make the work I do harder and make actually having good interventions for these youth difficult. Even people who want to do a good job will sometimes hesitate because they don't know if they're allowed to. They don't know if they do a job like this, if they'll lose funding, and that's a real concern. So there are a lot of ways that because of some of our cultural bias or institutional bias that we don't even try. Like we self-select ourselves out of ways to help these kids. And as I keep on talking, like unless we have something that helps these kids in particular or finds ways for them to actually talk about their problems, the discrepancies are only going to increase in these systems. And then uh, even if another tragic thing with this is that even if we can identify that these queer youth aren't in safe homes, we actually don't have a lot of good avenues for youth experiencing that. There's a lot of fantastic people, I want to say this, within our foster system that work with on trafficking that I partner with quite frequently, like the Red River Child Advocacy Center. But to talk to them, it's knowing it's not always enough. And it's this kind of unfortunate gray area of if the abuse doesn't get to a certain level, it's permissible. And that's kind of what we exist in as a society, where we don't have good, adequate interventions for this for any population. So it's even worse for our queer populations when this stuff happens. Any way that people are falling through the cracks, our queer youth are falling in those cracks at 3 to 5 times the rate, depending on what we're measuring. So everything here is a risk factor. If we don't identify these things and these youth are experiencing that leads to higher risk factors. If we're not talking about the specific abuses that can be happening to these queer youth, or they don't feel safe to talk about them because they're afraid of being outed, those are risk factors because we're not addressing some of the key components to the trauma they're experiencing. So we have systemic issues, prejudice, it becomes invisible. And if you think back to those questions I asked earlier about how long do you think we've been tracking this problem? Well, I kind of went back to 2016. We still had queer youth in 2015 and 2010 and 2000 that we never did anything for, that never had any intervention to help them. We are doing better today than we were. So there's a concept I want to talk about here, and that is something I call microdosing suicide. And that's not a like you're not going to find that in a published paper or anything like that. That's just from my experience, from the work that I do. And I think that we often look at suicidality very much in an attempt. Like that's what we really care about. Are you planning an attempt? Are you planning on making an attempt? Have you had an attempt? Like that's how we think about suicide often. But I think that for a lot of these youth in particular, and I can tell you this is my own story, you don't make big decisions like that often. What you do is you make little decisions. And you make little decisions every day of your life. And that can be maybe you eat a lot more than you need because you don't really think you're going to be here in a year. You don't go to class because what does that matter? You start drinking more than you necessarily want to because it doesn't really matter. Like you don't really see yourself here in a year. And drinking a little bit more one night, that isn't a health risk too much. That isn't too much of a problem. But you make those little decisions and they keep on adding up to a bigger decision that becomes easier and easier to make when you make all those little decisions to slowly erase the protective factors in your life. As you start to slowly give up on your health and your connections and your family, as you slowly do these things, you're doing it because you don't want to be here and you want to make it easier to not be here. So I think that a lot of the behaviors we see are more microdosing suicide, and that leads to a loss of opportunities and loss of protective factors over time. Like I said, though, that's just my own experiences with these things. That's not from data or research. That's just from me doing the work that I do. So the thing I want to hammer home in this part of it in particular is the importance of a single warm memory. So the truth is, there are a lot of queer youth that we cannot help no matter how much we want to. We can't identify them. They don't feel safe to open up to us. They have already checked out. There's a lot of reasons that a random trans youth living out in like Rugby County or something like that, they don't realistically have any support or chance. But we can still do something to really impact these youth or adults wherever you see them in their journey. And I call that the importance of a single warm memory. And this is, again, this is my own experience here. I don't have this from like a research or data perspective, just from the work that I do and the things that have impacted me as a person. And I think that when everything else is going bad in someone's life, their family has not been good, their school has not been good, they don't really see anything out there that makes them want to be alive. I think that if you can give them a single warm memory, I think that's a huge protective factor to make them want to still be here. And that could be one interaction with them where you talk to them as a professional and make them feel safe and heard. I think that when we can't do everything we want to, when we can't take a kid out of a home that's not good for them, we can still give them a warm memory. And I want to end for this section on protective and respecters on this idea because it is so difficult to be a professional and to be empathetic and to care and to know how tough it is for so many of these people. You don't get into health work, you don't get into therapy or counseling or anything like that because it was like the highest paying job. You get into it because it's something you deeply care about. And I feel most people who work as teachers or professionals in counseling, like they're not the ones that saying trans individuals shouldn't have any rights. Like it's people who care deeply about a lot of people. And that warm memory, there is some research to say you can have hope with it. So I think I shared this in one of my other slides. It's one of the important ones I like to share. And here's a picture of a goat to make the sad go away. It's, I think, do I get closer? No, that's the closest we get to the goat. But I think that I've been through a lot of trainings, specifically on suicide prevention and stuff like this. And we get into some really heavy topics, right? If you're someone who has treated these youth, as I talk through these experiences, you are probably having memories of kids you served and problems that they've had. And maybe they didn't end in ways you wanted them to. Maybe that relationship didn't end in ways you wanted it to. Maybe they ended up moving and you weren't able to help them. And it's tough to sit with that. So I want you to take a moment to kind of breathe. Just look at the goat, have a good time, breathe in for like 5 seconds, and breathe out. I might have said this in my other trainings, and this is something I really want professionals to know about because secondary trauma is one of the things I specialize in, and that is we can't save everyone in this work. We want to. Yeah, we want zero suicides. That's what we want, absolutely. But realistically, it's not going to happen. Our job isn't to do that. Our job is to give as much hope to as many people as possible. And that's something we can achieve every day. We can do our best, and it matters every day. We don't measure our success by who we lost or didn't. We measure it by the work we do every single day to increase the opportunity and hope that people have. And what we find is one affirming adult can reduce the suicidality in queer populations by 40%. And I think that's the warm memory. I think having one person who you feel safe with, I think that's such a strong protective factor that none of the other stuff hits that hard anymore if you can have someone like that in your life. So I want you to know that even with everything else in the system being on fire or being awful, you can still have that impact as a person. And there, you don't have to be an expert in this. You don't have to know everything about suicidality or queer populations. Just being a pretty decent person who's empathetic, actively listening, and trying to make someone feel like they matter is going to go a really long way with this population. So what are we doing now? How do you get involved with this? I do want you to know that I guess there are some like contention about queer identity and how we treat it, especially the trans individuals. The American Psychological Association just released a very strong public statement about trans care, specifically that it should be accessible and it's medically necessary. I will say that every major medical organization in our country supports trans care and supports access to trans care. I will say that North Dakota, we've never really seriously addressed LGBT plus suicidality in our state, and I'm the expert on that. I do the research on that. If someone knows more than me, I would love to meet them because I could use help, but we really haven't. It tends to be me for some reason. But there are a lot of organizations that are doing good work now that never have been before. One of them is Indie Hopes. They specifically are a grant-funded CDC suicide prevention effort targeting 21 counties with a rural populations, veterans, and LGBTQIA plus youth in particular. So that's an organization doing a lot of great work that you can connect with, and they're trying to build better resiliency across the state. There's also a thing called the GLS grant, which I don't include because it's not specifically LGBT plus youth, but it covers the other counties in our state, so the northeastern counties. The other organization is FirstLink. FirstLink answers our 988 suicide crisis line. They answer our 211 line. They are fantastic. I work with them very closely. I love the work that they do. This is a number you want to make sure all queer youth have and can call. If they call 988, they can hit 3 and talk to Trevor Project, which is specifically a suicide prevention programming for our LG plus youth. But if we could do one thing to reduce suicidality in the state, it is make sure everyone knows they can call 988 and that the people who answer that line care, that they don't get into that work except for because they want to, and they want to hear from you. They want to talk to you. So one thing I will say is that you have to kind of always imagine if you're treating queer populations, there's some trust deficits in our system. But specifically, what I try to tell people is that they don't want to call the police on you if you call this number, and 95% of the calls don't end in any sort of welfare check or intervention. They really only do that if you are an imminent and immediate threat to your life. So they do have to in some cases, but it's not something that they're just going to, oh, you're calling for suicide? Okay, we'll have a cop car coming to you in like the next 2 minutes. That's not how that works, and it's important to let your clients know that they're not going to be committed if they call. Most of the time. Raven's Mom is another good organization. It does resiliency for survivors of suicide, specifically for queer individuals who have lost queer youth. So that's a larger demographic than we want it to be. They operate out of Minot, but their goal is to eventually be a statewide organization. So they're another organization that does specifically a lot of work with our LG plus youth for survivors of suicide. The American Foundation for Suicide Prevention also does a lot of great work on the policy and research side of it. They have the Out of the Darkness walk coming up in September, where you can, a lot of people get involved in suicide prevention that time. And I was part of that walk last year, and it was amazing to see like 2,000 people show up and walk around the area that we were in. I forget where it was because it's like a South Fargo area. And even though I grew up in Fargo, like That South Fargo area is getting weird, right? Like, I don't know, like it starts to become like Land of the Dragons to me there, and I don't know how things connect anymore. Like the far south, far west Fargo is just it's a whole different area to me. This another grant that happened was there was a major education grant. It's called the School Health Hub, and it was designed around training counselors in our state in particular, but it also has some research and programming for our queer youth in general. So looking at GSAs in elementary school and how effective they can be. But that's a cool program that's happening. And then Harbor Health Initiative is actually something I'm the program manager for. And there's a directory of all the LG plus affirming providers on there. And I also run the Safe Harbor project, which is intentionally trying to get more support within our K-12 school system. So all these organizations are organizations that are actually trying in some ways to reduce or prevent suicidality for our queer population. So if you're interested in getting involved in that at all, if you want to know more information about it or get connected, like these are the places to talk to and get connected with. In terms of current needs, I would say that everyone being more competent in suicide prevention is a general need. Like it's a default good the more people that know about suicide prevention efforts. So this training here was covering like the data, covering some of the ways it impacts queer youth. But if you want stuff like how to have these conversations, the appropriate ways to give like the QPR training for suicide prevention, like I have those listed and you can connect with me. I always try to make sure every time they come up, I share them. But the American Foundation for Suicide Prevention and First Link both host these trainings. There is a suicide prevention training coming up on the 26th, I think, of March. So these are all things that you can take. Some of them are community level. You could take them regardless of your background. Some, like the assist training, are 2-day long dedicated training, so you know exactly how to reduce suicidality in your care. So I always try to put information and advocacy around that. I will say our current needs are, if you want to think about how you can get involved in this work, think about how your organization can make sure it's mitigating some of the trauma that happens for queer individuals that you're identifying, finding some ways to identify safe avenues for them to come out to you, that you are making sure that your staff is well trained on things like the cultural competency side of it, that you have good understanding of the suicidality, like all these things. Just make sure your own organization is doing well, that they have good trainings, and that you are thinking about how queer individuals are going through those organizations from before they even get to you throughout your whole care model and how they leave. Make sure that you have some ways to measure how you're doing for this population. The other thing I want to talk about is the secondary trauma needs, as I've already talked about before. But the CDC did a report that mental health crisis continues for health workers. And that is, we have so much trauma that we're dealing with in the health system, especially with COVID, that we haven't like addressed in any serious way. Like our administrators keep on telling us to work harder. But it's really important that we keep ourselves safe first. And the trainings that I give about school teachers or counselors, regardless of the limitations we have because of different policies or laws, like you need to make sure you are safe. Otherwise, you cannot help other people. That means taking care of your mental health. That means taking time off when you have it, knowing that the work you do matters every day that you can do it. And you need to take time off for that too. Another way of looking at it is looking at the whole system, and that's understanding that all these problems are interrelated. One of the ways we look at this is the social determinants of health, but it's understanding that the suicidality of queer youth is not just a suicide problem. It is a problem of resources. It's a problem of lack of opportunities. It's a problem of our entire system. Suicide is the end of the line. It is when enough of these systems fail someone that they don't want to be here anymore. So it's looking at everything. It's looking at mental health. It's looking at different things across our society, poverty, discrimination, food security. It's making sure that every person has the opportunity to thrive in their life. Another thing is the secondary trauma is we need to protect those that are serving these individuals. So making sure we have a child worker shortage, making sure there's good income for folks doing stuff like that, that we have compassion fatigue services, that we have stability in our organizations, and that we actually talk to each other about the work that we're doing. If you have questions, put them in the chat. I just have a couple things to go through pretty quickly, and then I can get to those questions. But basically, I want you to know that I will be doing the work that I'm doing for the rest of my life. I host a lot of data on my website in particular that is free and accessible. So if any things that I talked about today you are interested in, you can find them. If you have questions, you can email me. I put out a lot of different news and newsletters for people to basically understand a lot of the cool things that are happening across the state and help us connect to each other and try to build up success across our entire effort. So it's not just us working on homeless issues or us working on mental health. It's all of us together working together to make sure our needs of the state are met. And I also put together reports like this is for a secondary trauma report. So if you work closely as like a first responder, this is for you because maybe you don't want to call 988 because that's your coworkers. This is a essential resource for our queer youth across the state that they can access. And then I actually do a lot with journalism too and making sure that we have 988 in reporting. So I have every affirming medical provider. I have trans-specific resources, suicide prevention resources, insurance guides. Just talk to me and I'll help you. That's like the later part of this training. So the very last part is I really want to hammer home. One, thank you for spending your time with me this morning. And everything you do matters. Like at this point in my life and career and advocacy, like anything you do has so much impact because even if we can't help some of the queer youth, the better our youth are doing in general, the better that population is going to do and the less harm that queer youth might experience. Any way that we can make someone's life better and make them feel loved and seen and supported helps everyone out in some way. So please connect with me if you want to be involved in any of that, if you're interested in any of the work that's being done, and know that whatever you do matters. It really does. It's hard to see. You don't get told enough, but thank you for what you do. And that is my training on suicide prevention this morning. So thank you for joining me.
Feel free, if you have any questions, to put those in the chat or unmute yourself and certainly ask Faye any questions.
Are you hearing my bones crack? I feel like that was really loud. Sorry.
I didn't.
Oh, I should put my email if that's not in the chat yet.
Nope, yeah, go ahead. No.
Okay.
Okay. And I will certainly send out a follow-up email as well with Faye's slides and so you'll have that information in there as well. So thank you everybody for joining us today. It looks like we're about right at 1 o'clock. So thanks Faye for the great presentation.
Thank you. Thank you for having me.